showed in the slideshow last time. Okay, but thank you. There we go. Thank you. So we see here, cut away the diaphragm, and the attachment points here. There's the right crest here. The left crest is hiding behind the thoracic aorta. Those things works today. So it's a dome-shaped structure with the three muscles. I'm not going to have you memorize them, obviously, that are all connected with the central tendon here. And like I said last time, composes the inferior border of the thoracic cavity. We have several structures that go through it. You need to know the locations of the aortic hiatus here down. Down at the base, posterior base of the diaphragm. We also have the opening for the vena cava there, kind of in the central tendon area. And then you also have a hiatus for the esophagus to go through here at the esophageal hiatus, kind of tucked in here. Several vessels and nerves go along with those major structures through these hiatuses. But I just know the major structures that go through them. I also want to note the innervation. So the phrenic nerve, as we've been learning in laboratory, comes down to the diaphragm, passes through the diaphragm, and innervates it on the inferior side of it. So you can see here the phrenic nerve pointing the inferior aspect of the blood supply. Let's make sure I keep it straight here. Is through the, where are they? I don't see them on here. Oh.
Is it the muscular thing? Muscular thing, is that?
Yeah, that's one of them. Here, I was looking for the superior phrenic, but I think they're showing them as the branches, which are the right pericardiacal phrenic arteries here, and the left one here. Anyways, so, and we also have some inner arterial supply through some of the intercostal arteries, which they do not show here. And then venous drainage, all of the veins that drain the diaphragm either drain into the brachiocephalic veins or the azygos system of veins, which includes the azygos, hemiazygos, and accessory hemiazygos. They are not shown on here, but I believe I have those in your notes. Huh?
So just all of those? It's not like order?
No, they just, those are just the ones that they drain into. Eventually the azygos will go up into that area as well, but these are ones that more directly drain the veins coming from the diaphragm. Okay, and then innervation, like I said, is through the phrenic nerves. So that's it. Know the hiatuses, the innervation, and the major arteries and veins supplying the diaphragm. So then, when we talk about the mechanics of breathing, obviously no contraction of the diaphragm pulls it down in the anterior cap into the inferiorly, and increases the capacity of the thoracic cavity. We also have movement of the ribs that help expand the thoracic cavity. So as, excuse me. As you inhale, the sternum moves superiorly and anteriorly, and they liken that to a pump handle action. And that action is due to the elevation of the ribs. In addition to elevating the sternum, elevation of the ribs also causes lateral elevation of the lateral portions of the ribs. And the shaft of the rib also expanding the thoracic cavity, and they liken this to bucket handle movements, just to help you remember it. So when it all comes down to it, together we have lowering of the diaphragm, we have the ribs elevating, we have the sternum elevating, that increases the capacity of the thoracic cavity, and the parietal pleura is going to pull out with the rib cage, and then the thin layer of fluid in the pleural cavity, the cohesive and adhesive properties of that fluid also pull the visceral pleura and then the lung with it out, increasing the capacity of the lung and then causing air to flow in. During exhalation, we have relaxation of the muscles, and everything kind of relaxes down to normal. So the diaphragm moves back into its dome-shaped structure as it relaxes. Okay, so just a simple overview of that. I don't think we need to go further into it than that. Any questions on diaphragm, pleural cavities, all that good stuff? Okay, so then we'll move on to the mediastinum. And it's divided into several sections, so it's the space between the pleural cavities, between the sternum and the vertebral column. Remember at the sternal angle and the vertebral column T4, T5 level, we have the separation of the superior mediastinum from the inferior mediastinum. It also is the superior, what's the word I'm looking for? Superior end, we'll just go with that one, of the pericardial sac. So when we're talking about the mediastinum, a lot of it's in reference to the pericardial sac, because that's basically the middle mediastinum, is everything in the pericardial sac. Whereas superior mediastinum is everything above that level, anterior mediastinum is everything anterior to the pericardial sac. And the posterior mediastinum, everything obviously posterior to it. So today we're going to charge through the middle mediastinum, which is the heart and the pericardial sac, pericardial cavity. So we have basically 3 layers to the pericardium. We have the fibrous pericardium on the outside, which is a tough fibrous connective tissue layer. And that is connected to the sternum via the, make sure I get the name correct, sternal-pericardial ligaments. Attach it to the surface of the sternum. So, right back down. And these ligaments basically just help to hold the heart in place in the pericardial cavity. Excuse me. Right. Inside of that, we have the serous pericardium. made up of the parietal layer and the visceral layer. And these two are thinner membranes. The parietal layer is associated with the fibrous pericardium, and the visceral layer is adhered to the surface of the heart. And also is known as the epicardium. In between those, we have the pericardial cavity, which is a fluid-filled cavity, and again, just helps cushion the heart. And if there is buildup of fluid, extra pericardial fluid in the heart, we can have what we call pericardial effusion here, and the treatment would then be to insert a needle into the pericardial cavity and withdraw that extra fluid, and that would be a pericardial centesis or pericardial tap. So, yeah, just fits in the notes. At least got that far. You can also have inflammation of the pericardium, pericarditis, which also cause referred pain, and can often be mistaken for myocardial infarction, so heart attack, because it's a similar pain situation. But if you lean the patient forward, it relieves the pain of a pericarditis case, and well, it does not in a myocardial infarction case. So just a little clinical application there. So that is basically what I want to talk about for the pericardium. So then we'll talk about some of the innervation of it. So the right phrenic nerve, as it's traveling down to the diaphragm, sends off branches that goes through the fibrous pericardium and innervates the serous pericardium. And we also have the blood supply by the pericardiac phrenic vessels. Excuse me. Goodness. All right. So, I'm going to skip over the reflections of the pericardium that's listed in your book. I think that's extra information that if you need to know it someday, you can learn it, but I think for this class it'd be sufficient to just know that the overall structure of the pericardium. One thing I do want to mention at this point here, so at the points where the great vessels emerge out of the heart, the visceral and parietal layers of the serous pericardium become continuous. So you can see here they kind of loop back on each other and form a continuous envelope there. Kind of a good way to create that border around the roots of the great vessels that are coming out of the heart.
Sure, can you repeat that one?
Yeah, sure. So, sorry, my voice isn't doing so well today. So the parietal and visceral pericardium up at the roots of the great vessels, so like the aorta and the vena cava, they come together and become continuous with one another, so it basically merge into each other, creating a solid envelope around that pericardial cavity. All right. So then, let's talk about the heart. So first of all, just a wonderfully rough schematic showing different surfaces of the heart. And we'll look at each of those surfaces on a diagram of the heart as well. So ones you need to know are the base, so that is the posterior surface, adhered to the back of the pericardial sac. Excuse me. And we have the anterior surface here, which faces anteriorly and superiorly. diaphragmatic surface, which is in contact with the diaphragm, as you might guess. And then the pulmonary surface is on either side. When we're talking about edges of the heart, we also talk about the inferior margin, which is a sharper edge between the diaphragmatic surface and the anterior surface. And then the obtuse margin, which is more rounded edge on the surface between the left pulmonary and the anterior surface of the heart. And then obviously the apex is the pointed inferior and superior, or inferior and anterior aspect of the heart. And the apex is just deep to the fifth intercostal space. Which will come in handy when we talk about surface anatomy. So we'll start off with an anterior view of the heart. So here is the anterior surface, and it's through here, sort of. And it's predominantly excuse me. Predominantly the right ventricle, with a little bit of the right atrium and the left ventricle composing it. You can see kind of this rounded margin here. So here, the obtuse margin, they show that rounded margin as it curves over from the anterior aspect to the the left pulmonary base. Then we see on the base of the heart. The base of the heart is predominantly this interconnection here of the heart with the great vessels. So I've got a little bit high on the drawing there. And it's, since it is connected closely with these great vessels, it actually helps adhere the heart to the posterior surface of the thoracic cavity, helps hold it in place, the pericardium. So that is the base. And then finally, this is an image of the diaphragmatic surface. And we see here it is predominantly composed of the left ventricle, a little bit of the right ventricle, and a very small amount of the right atrium, and then also the left atrium, part of the left atrium as well. So learn to differentiate between these different surfaces.
Isn't
just
that-
help you orientate? Huh?
Isn't that the posterior part of the heart?
No, it's like the turned up. It's like the bottom of the heart.
Yeah, so up to about here-ish. Because the posterior part's kind of angled this way, and then the ventricles come down. So,
Okay.
so kind of to here-ish. Yeah.
So where does it like separate between the left pulmonary surface and the diaphragmatic surface?
Yeah, so it's kind of when you're looking at the heart
Oh,
3D,
oh, I see.
you'll see like
Okay.
slightly
was thinking
flatterish
something totally
surfaces, and then a curve.
It's like an apex, or you're talking?
No, along the border.
Okay.
Without having a heart in my hands, it's hard to show.
Yeah.
But let's take a look at that in the lab time sometime,
Okay.
and you can see like there's just a curve as you're going around the ventricles. Around the surface of the ventricles, you'll see some flatter parts. It's not like completely flat, and then there's some more curved parts. It's those curved parts that we're talking about for the margins.
Okay.
Okay.
Yeah, I'll have to.
Yeah, it's something you just have to look for. So it's just something to point out to look for when you're looking at it. Yeah. All right. So then, just for a little more practice, looking at imaging. So this is a typical X-ray. And you can see the heart outlined here. So sitting at midline and then off to the left of midline. You have the left ventricle along here. the right atrium poking out here beside the vertebral column. See the pulmonary trunk coming up here, the aortic arch kind of starting over on its bend there, and obviously the apex here. So I just start practicing this as you get further on in your program. You'll have courses that actually really start hammering in this radiology, and the more you start looking at them and get an idea of what you're looking at, the easier those courses will be. The surface of the heart also has a couple other, what I'm looking for, features. So one of them is the coronary sulcus. So this is just a groove between the atria and the ventricles, and runs around the whole, basically the whole heart, and has several arteries and veins that run along in it, which we will talk about in a moment. And then we also have the intraventricular sulci, so we have one on each surface of the heart, as you guys have been learning, anterior and posterior interventricular sulci. And as we've been learning, we have the major vessels that run down that towards the apex of the heart. And the anterior and posterior interventricular sulci actually are continuous and continue on just off the apex of the heart, so kind of just off to the edge there. And we will review those vessels in a moment as well. Here is just an image of the posterior interventricular sulcus here, showing those vessels. Then I'm sure we all know cardiac circulation system. So we've got two basic circuits. We've got the pulmonary circuit here, and then we've got the circuit that goes to the body. And the two sides of the heart kind of acting as independent pumps. So we'll just start picking apart the different sections of it. So here is a cross-sectional MRI image where you see the different sides of the heart. You kind of see how they are divided into the two halves here. With the left atrium and ventricles, so you have kind of the thin-walled atrium here, the thicker-walled ventricles. So atrium, ventricles. There. You guys see where they got the two-sided pump thing from, and the way the heart actually looks in these cross-sectional scans. Come on, it's not going. There we go. So then let's talk about each of the different major components of the heart. So this is the excuse me, right atrium, and it is receiving blood from the superior and inferior vena cava, and also the coronary sinus. So they open up into an area called the sinus of the vena cava, and that's just a smooth portion of the heart. So you can see in the diagram, it's a very smooth surface. It's actually from venous tissue, so embryologically it's composed of the same kind of tissue that the veins are composed of, extension of those veins. And then we switch over here on this part of the atrium into what we call the proper atrium, which includes the more anterior aspect of the right atrium as well as the right auricle. And those have the pectinate muscles, so in your book they're called muscula pectinati. So we'll just do pectinate. So ridges, so those muscular ridges along the inside of the atrium that begin at the crista terminalis. So this is kind of the border. We want to remember the crista terminalis also when we start talking about the electrical conductivity of the heart.
Can you describe what the crista terminalis separates?
It separates the sinus of the vena cava. That's useful. from the atrium proper, which is what they call this, like the more anterior, not anterior, yes, anterior portion, and also includes the right auricle. Okay, a picture, nice. Okay, from there we move into the right ventricle. And we move through that, the tricuspid valve here. And so we have the tricuspid valve, has obviously 3 cusps, so 3 flaps of that membranous tissue. The borders of those flaps of the valve, the cusps of the valves, are attached to this tendon-like structure called the chordae tendineae, which are then attached to the papillary muscles here. We have 3 sets of papillary muscles. And the papillary muscles are modified trabeculae carnae. So the trabeculae carnae are kind of like the ventricle's version of the pectinate muscles. Kind of rod-like or rope-like structure of muscle within the lining of the within the myocardium that's help to function the proper what's the word I'm looking for? Contraction of the ventricles. Another modified trabecula is the septomarginal trabecula, which again will be important when we're talking about the electrical conductivity of the heart, as it provides a bridge from the septum to the papillary muscles, and we'll talk about that in a little while. Then the output portion of the heart, so or the right ventricle, goes up into the conus arteriosus. There's kind of a cone-like cone-like structure that leads to the pulmonary trunk. Through the pulmonary valve. All right. So let's talk about the pulmonary valve. This is semilunar valve, which means it has these funny pocket-shaped cusps. So the tricuspid valve, we go back to that. That far back. You see that the flaps or the cusps are a little flatter. Whereas the semilunar valve has these very distinct shaped cup-shaped cusps. And the way it works is when the blood is rushing through, it pushes the cusps out of the way. And then after ventricular contraction, the blood is going to start flowing back this way and will fill these pulmonary sinuses here, so the little interior parts of those cups, and actually force them open, kind of like a parachute would. And then that functions to close the valve. And prevent backflow into the heart. Right, so this is the pulmonary valve. All right, then let's move over into the left atrium. Unlike the right atrium, there is no sharp definition between the sinus, where you get input from the pulmonary veins, and the atrium proper. It just kind of smoothly melds one into another. So then they don't really show it here. And then we have obviously the left auricle, which is that cone-like extension of the atrium proper. Also on the wall of the atria, so the interatrial septum, we have the leftovers of the foramen valley, which in the adult is called the, I'm not going to spell this correctly, somebody help me spell it. Fossae, right? Ovalis. Spelling is not going to be happy today. Does it have to be on the end? No, it doesn't. Okay. That's weird. Okay, fossa ovalis. And so you can see that a little better. I'll go back to go. Here we go. Nope, same one. Here we go. Same as the, is it loud and distracting? Mm-hmm. I'll close it. So you can see that on the wall of the right atrium. So then, the fossa ovalis is the leftovers basically of the foramen ovale. And that, can anyone tell me what that is embryologically? What's the point of having this foramen ovale?
It's to bypass.
Hmm?
Bypass the pulmonary and circulatory system.
Exactly, so if it allows bypass of the pulmonary circulatory system while the lungs are non-functional during fetal development. Very good. And then we pass into the left ventricle via the mitral valve. Oh, I forgot we had this in here. All right, so here's just another cross-sectional image. This is a CT scan, where you can see the pulmonary veins coming in from either side and entering the left atrium there. Okay, back to the mitral valve. Okay, come back. So we pass through the from the left atrium to the left ventricle via the mitral valve. This is a bicuspid valve. And one way you can remember it is miter has 2 points on it, so mitral valve has 2 cusps. One way to remember. Those are also attached to chordae tendinary and papillary muscles in the wall of the left ventricle. And since what I'm looking for, I should get more sleep at night. Anyway, so when the ventricle contracts, and there's this picture for both of them, there's also a contraction of the papillary muscles. And those work together as the ventricle is contracting, the force of the blood is pushing the flaps of the mitral valve and the tricuspid valve back into the atria. But the papillary muscles also contract, and that prevents them from actually everting into the atrium and allows the valve to actually close properly. So that is why it is important to point out the, I can't remember the name of it at the moment. Where is it? There we go. The septomarginal trabecula, because that is kind of the shortcut between the atrioventricular bundle that we'll talk about in a moment to those papillary muscles to make sure that they are contracting within the correct time frame during ventricular contraction. All right.
I think we're out of time.
Yeah.
Oh, is it time already? Oh, geez. Well, that didn't take very much. Well, let me just cover this in the last minute. So the aortic valve, this is the semilunar valve from the left ventricle out. And again, it's another semilunar valve. So we've got this structure kind of like pulmonary semilunar valve. But I want to point out that the openings for the right and left coronary arteries are in the sinuses, and in the aortic valve, we call them the aortic sinuses. So that then as you're getting the backflow through the aorta after ventricular contraction, it's going to force blood into these sinuses and out through the coronary arteries. That's how we get actual the blood flow through the coronary arteries. Okay, so with that we will end, and we'll begin on the vasculature of the heart next time.
Yeah.